is talking about and organizing a program, and that too wonderfully by doing an evening course so that all working professionals can also attend. So I think this has been one of the most innovative ways I have seen this sort of a FDP being done. So I hope my screen is visible to everybody. In case it's there in problem, please let me know. So you see, uh, today everything in the world is about data. We may be talking about anything, and the recent craze also we found is like we all are hearing about Chat GPT and others. So it is all data which is taking over, and data then followed by analytics, and it is basically information or the crunching of data which is actually going to be the new gold in the coming times. So that is what makes us have hospitals also driven by data. Now, we have very recently gone through the COVID pandemic, and in fact, some places in the world are still going through it. And all of you are have seen how we have been able to fight through it. But if you look at what was the important changes which came during COVID, for example, we had a lot of information technology. For example, people said it's work from home, work from home. Or if I am taking a class now, sitting in Delhi, and all of you are connecting from different places, I would say it's all thanks to COVID that it has become mainstream. So, what has a disaster helped us? A disaster has helped us mainstream a technology which was sometimes a little niche technology, not that widely adopted or not reached the last mile. But today, this has become a very, very standard thing. Similarly, we got data analytics to improve our efficiency. We have digital consultations. Nobody could imagine a teleconsultation. I still remember uh, 1 year before COVID, when we used to discuss about the fact that why can't we just consult on WhatsApp with a doctor. It was like everybody used to say there is no legal framework, it is liability issues, there are other issues. Today, suddenly, if you realize teleconsultation has become a standard thing, and why it has become, the government enabled it through a framework, and day by day it is picking up. So today, when we talk about a teleconsultation or digital consultation, it is not something which is we are providing. It is something which is being demanded by the patient now. Even after some point of time, um, any one of us who is a patient will start asking the doctor that why to show you a blood report, I just need to come. Something which was very standard is today outdated, and technology is taking over. Similarly, predicting or analyzing the risk of epidemics. Now, this is where our key area of simulation is picking up. You see, there was weather prediction which used to be there. Today, we have COVID modeling which is happening. That how the wave will grow, what is the time it will peak, how we need to plan our resources. You see, ultimately, what is that? It is ultimately intelligent use of data. It is intelligent use of historical data. It is intelligent use of epidemiological data. It is intelligent use of, uh, you know, data which helps us prepare better. And similarly, artificial intelligence. Some of you may have heard about Chat GPT. Chat GPT is taking the world by a storm. I was reading a few days ago that it has destroyed all the myths about a product development cycle and the pace at what it has picked up. So, if you see, we as individuals have seen the growth of mobile industry. There was a time when mobile used to be taken as a very, very expensive um, limited use item. Today, you have the remotest person using mobile. Similarly, digital payments picked up. And now the next biggest thing which is picking up is AI. And I would extrapolate the fact that AI is somewhere or the other at the back end related very, very deeply to stimulation. So now, what are the factors which are triggering a traditional shift? To understand why we need to adopt these sort of new tools or technologies, you must understand what is the kind of factors which are helping us or making us go into this shift. You see, we have the highest non-communicable disease burden in the country, in the world, right? And it contributes to around 60% deaths. There was a time when we used to say people die because of cholera, people die due to malaria, people die due to a lot of transmittable diseases. Today, if you see what are the biggest causes of people's death, cancer, people are dying of cardiology, cardiac diseases, right? Stroke. So, the non-communicable disease burden or the lifestyle disease burden is picking up in India. Now, similarly, there is an Oxfam inequity report which says that the number of hospital beds per 10,000 population between 2010 and 2020 reduced from 9 to 5. But you see, we have only 5 beds still for every 10,000 population of ours. And India has 5 beds and 8.6 doctors per 10,000 of its population. Now, ideally, if you see a global ratio of around 20 beds per 10,000 population and around 20 or say 15 doctors is taken as the bare minimum. So, and that too, we are speaking when the numbers, what we are talking are not those which are 101% authentic numbers. There would always be a bias in the numbering, not because we report wrongly, because there will be people who will not come and report those numbers. So there are a lot of health disparities on that account. Same way you have ICT factors. For example, government is going big after wellness and Ayushman Bharat. And all these systems are ultimately backed or supported by digital health, right? There are an increasing number of health seekers, as I told you, for teleconsultations. And today, India ranks 145th out of 97 countries in the healthcare access and equity. This was the report in 2016. We may have improved better. We don't have the same report today, but we are still a long way to go. And we need to understand that we are, because of the limitation of people we have, because of the lesser number of hospital beds, the lesser number of doctors, while we are trying to increase those numbers, we also need to increase the efficiency in our system. And how would you do that? You see, you have to understand that earlier we had traditional hospitals. From traditional hospitals, we moved to digitized hospitals. What were digitized? Digitized hospitals was your registration maybe got computerized, or maybe your lab reports were typed. So those were a little digitized hospitals. Now we are mostly a lot of private hospitals, big private hospitals are today at connected level, connected hospital level. The government hospitals will be somewhere between these two. But ultimately, where we are moving? Ultimately, we are moving to smart health systems. We are moving to systems that integrate patient-centric care and break down the care between care settings. We all connecting on a Teams environment is one of the biggest example of how we have evolved from what we were a few years ago to what we are today. Now, let us understand that what will be the key, outcomes of a facility which is driven by data. It will be improved patient experience. We will have better prediction and prevention. We will have elimination of medical errors. We will have a precise care delivery, and we will have more efficiency and cost saving. Now, efficiency and cost saving is something where we all need to focus as we move forward into our next 15 years or 20 years time, which is where, because we are not a country where we have excess resources, we need to bring in a lot more efficiency in our functioning. Now, let us try to understand that how are things going to improve. We are having AI, we are having virtual care, we are having robotics, we are having Internet of Things, and then ultimately we are having platforms. These platforms are basically your interconnected systems which are providing you data. Now, when you have data which is available, it is this data, how you use, is what is going to help you in a hospital environment. Now, try to look at a very few successful examples before we come to our core simulation example. You see, surgeons are now using ICT to improve patient care experience by enhancing the accuracy and outcomes for patients, simplifying the administrative processes for patients, and by empowering patients. Right. The University of Texas Science Center at Houston performed a minimal invasive procedure with the help of artificial reality, which was used to plan a route and visualize critical structures. In India, if you want to look at some very, very successful examples, the eSanjeevani is a telemedicine initiative of Government of India. It has recently touched 1 million teleconsultations within a period of very short period of 2 years. Similarly, Defense Research Development Organization, the DRDO, has developed a tool to diagnose COVID. You see, X-ray is something a technician can take. To diagnose it, you need doctors. Now, you have AI tools which are diagnosing almost 96.73% accuracy that whether this is COVID or not. And then EICU. EICU is helping you, um, you see, treat patients remotely, bring that expertise to the remotest place. So, what are the barriers to transformation still? But try to see the barriers are technical, that is, lack of standards of IT adoption, interoperability, data quality. Then you have workforce limitations, lack of trained medical workforce in IT systems, financial systems, the cost of developing and lack of financial incentives, change management, where is a huge behavioral change, low patient awareness on IT, and then governance challenges, where all the different government bodies need to come together. Recently, we have been seeing this in a much bigger manner happening. During COVID, we actually saw the convergence happening in a very, very positive manner. Now, when we are talking about the adoption of IT in hospitals, we need to understand that there are certain challenges which need to be addressed also, right? Which includes training, education, maintenance, investments, digital leadership, regulations, availability of technology, existing infrastructure has to be upgraded, and data security is something which is very, very important. Now, to give you a brief example of how, you see, I have tried to bring you a very, very simple first level or a very short level case to showcase how simulation can be used in a healthcare setting to understand. Now, you see, we had a very unique problem. Let me come to and show you first the photograph. So, you see, this was a patient waiting area we had, and the patients would come and queue up at this counter to get themselves registered. Now, people said that patients keep on queuing at these counters. We should try and put more chairs over here, right? This is something which is very common, which you would say. But then we had another thought which said, put don't put chairs or put lesser chairs, but give them more space to queue, because when you are putting chairs and making them sit, the you are able to adjust lesser number of patients in this area. And then we had area outside this, which this was an air conditioned area and this was a non-air conditioned area. So the point was that if you make more people sit in an air conditioned area, um, or stand in an air conditioned area, you give them more comfort versus when you make them stand outside. So this was a case where people would not agree to saying which of the two answers is correct, whether we should put chairs or we should not put chairs. So we ultimately built two simple simulation models. One was with chairs and one was no chairs, right? And we wanted to compare the impact of a chair removal strategy, right? So what was the challenge involved? The challenge was we had to do an accurate 3D model of our area from where we wanted to do this. So it requires you to take dimensions. It requires you to a little bit develop a flow or a process that how it will work. And then we had to write a script to say that. So this was our patient flow diagram, very simple diagram, we had one fast track entry where you would be old registered patients coming in, entering. And then we had current entry and we had UHID entry. All of them would come and they would come and stop in a waiting area. From a waiting area, they would go to a registration area. Registration area, they can go to multiple exits. So this was our kind of, we had an AutoCAD which we imported. If you don't have an AutoCAD, you could actually do a very simple drawing and try to take dimensions and then do it there. So if you are able to see this thing, these are the counters which are there on which the patients come and get themselves registered. And these are the areas where they can either sit or they can queue. And then we have space outside this where it is not an air conditioned space. So the moot question you see or try to understand was that putting chairs and having lesser number of people inside is beneficial, or having people queue is beneficial. The metric of benefit was that if people stand in an air conditioned environment, they are more comfortable than standing in the hot sun outside. Right. So this was the patient arrival period which we had. Then we also have to do a patient arrival rate and a seating capacity. So this is something like, this is the data which I am speaking that you need to know. You need to know your patient arrival rate. You need to know the seating capacity. You need to know your patient flow rate. You need to understand your hospital floor plan. You need to have registration timings. You need to know the patient line capacity. So every queue, how many can stand, and then patient types. It is nothing out of the blue. It is something which is common sense. You would actually, if you start thinking, you would do. But what we may not be able to do without a simulation setup is that we may not be able to convince the policymakers that the outcome would be this versus this. Right. So this is how we programmed our patient arrival rate and seating capacity. And then we did a analysis with chair model, that if we put chairs, right? So what we found was that the ratio of patients waiting outside to total patients went to a maximum of 53%. So you could have 53% patients outside and 47% patients inside if you are putting chairs, right? The average waiting time of current booking patients is greater than that of the this, what you say, is greater than the uh, other type of patients. And then more registration centers are needed in the current booking area. So we found that fast track patients are taking 33 minutes, current patients are taking 98 minutes, and UHID patients are taking 68 minutes. So what was, and also when we look at the utilization, the registration area utilization was almost touching 89% for current booking patients, while other areas were around 66% and 78% utilized. Now, this was the findings in a with chair model. Now, let us come to a no chair model, right? When we did that and we see that patients are just queuing here, we are not having chairs, we found that the ratio of patients outside to the total patients dropped to a maximum of 32%. So while there you had 53% of patients who could be outside at any point of time, in this case you had only 32%. So you were in a way benefiting around 20% more patients to be in a comfort zone than the other model where you are having almost 50% patients outside and 50% inside. The average waiting time also reduced significantly when we removed the chairs. It's something very simple. People will say, chairs or not chairs. It's such a simple problem. But if you see the comparative, you see your fast track time also reduced, your current time reduced, your UHID reduced, because people are in queue, nobody is wasting time. They are almost in queue here for 20 minutes, and in the current booking is where they're around queue for 75 minutes. So, but then we found that the utilization of counters has increased to 97% in the registration area, 2, so, and also in 3. So this shows us that we still need to increase capacity, even if we are removing chairs or something, to bring down the time we need to have more capacity also in this area. Right. So what were the recommendations? The recommendations were very simple. With chair removal, the ratio of patients outside to the total patients decreased from 53% to 32%. More registration centers are needed in the current booking area to reduce the waiting time of patients and smoothen the patient flow. And then alternative queuing strategies can be planned and capacity addition can be analyzed and validated through simulation. So this was our, the first touch with simulation, where we try to do a very, very small study. Now, then this is something we have now published also in, it's original research work published in the Health Science Reports Journal of Willy. And in this, we did the simulation for the entire OPD complex for a new healthcare facility we built with 200 OPD rooms. So I have shared this article with you in your your Teams folder. Sir would have done that. If you want, I can open that and also show you a little bit of this. I'll unshare and again reshare my screen with you on the. Okay. Yeah, so I am sharing my article with you. Now you see, this was again a study we did. The background of the study was done to create and run a discrete event simulation in the outpatient department of a tertiary care cancer hospital in North India to project and optimize resource deployment. Right. Now, how we did the OPD process and workflow was as per the expected load at the tertiary care cancer center were finalized with various stakeholders. So we had a focus group discussion where we discussed that what is the kind of load and other things we expect. The finalized OPD process and workflow along with the OPD building plans were utilized to develop a discrete event simulation model for that OPD. The model for this OPD was pretty complex because it was not just about a single block. It was multiple floors and multiple layers to understand. And we simulated 5 different scenarios. So let us straight come to the 5 different scenarios we simulated. And I will explain you. So this was our scenario 1, right? The scenario 1 was that the initial patient load was about 40 patients per day. The resources deployed were 2 screening rooms, 2 DMG rooms with 2 doctors, 1 receptionist, 2 patient care coordinators, and 1 lab technician. And we realized that with these resources, the OPD finished at 3 p.m., which was also what we could see on the ground, because this is something which was initial start of the facility. It is a 200-room facility, and initially we started it very, very small to understand. The peak census at given point of time, any given time, was 25, and based on which capacity of the waiting area was initially kept at 30. This helped to provide seating for patients while they were consulting. We could see that utilization of DMG rooms was 83%. These are disease management rooms. And the utilization of doctors in there was 83.5%. So any utilization above 70-75% is taken to be fairly good. You can never have 100% utilization. That is very sure. If you are touching 90s, you need additional resources. Right. The staff state times also reflected the same. The utilization of receptionist, however, we realized was barely 11%, which clearly indicated that there was no need to augment in near future the reception capacity. So you see, I had 40 patients per day. My doctors were getting utilized at around 83%. The rooms were also getting utilized at 83%. But my reception was getting utilized around only 11%. Right. So this is what helps you, because otherwise, if you say that tomorrow I will make patients 100, you would automatically start multiplying every resource by 2.5 times. Something which is not required. Then let's come down to second scenario. In the second scenario, the patient load was increased to 60 patients per day in that model. with the same resources as in scenario 1. We realized that OPD did not finish at 3 p.m. Instead, 30 patients were to be seen, yet to be seen at 3 p.m. with an average waiting time of 115 minutes. The utilization of DMG rooms and doctors in DMG room was around 89%. The utilization of screening rooms was also around 83%. The average state times of doctors and patients were reflecting the same. The peak census crossed around 40 patients, and the capacity of waiting hall, which was increased to 50 to cater to the increased load. And instead of this, with the same load, OPD, instead of finishing at 3 p.m., finished at 5 p.m. So, you see, in this case, we realized that if we target to finish off the OPD by 3 p.m., it is not possible with those sort of resources, right? This is how we was modeling it. In the third scenario, the patient load was increased to 100, right? But the resources were kept the same. And we found that, again, the same thing. Did not finish at 3 p.m. 58 patients were still waiting. Peak census crossed 80. Average waiting time increased to 138 minutes, right? And the utilization of doctors and screening rooms increased to 93%. However, the staff state times in utilization of reception area, lab technician, receptionist, PCCs, all remained around 20%. Right. So now we came to scenario 5. In the scenario 5, because we saw in scenario 3 that doctors were getting highly overutilized, in scenario 4, we increased an additional doctor in the screening area and 2 additional doctors in the DMG rooms. So it was bringing 3 doctors in screening and 4 doctors in DMG. What we realized, there were some improvements in waiting time coming down to 128 minutes, with about 24 patients only remaining at 3 p.m. in the OPD waiting area. The utilization of DMG rooms and all was also coming to around 80%, but doctor utilization continued to be more than 90%. The peak census came down to little above 60, which decreased the waiting required. But the other staff utilization just increased to 40%. Now, you see, the benefit was that as my patient load is increasing, because I have simulation data, I am not increasing my support staff. I only increase the number of doctors and the number of to make sure that I am optimally utilizing. And also I increase the utilization of support staff to around 40%. Now, the last scenario, what we did, an additional floor was opened to cater to a load of 100 patients per day. Based on utilization figures from scenario 4, the screening room was found to be the bottleneck. Therefore, all the DMG rooms were now shifted to first floor, and the capacity of screening rooms was increased on the ground floor. With increased manpower and additional floor opened, the OPD finished at 2:10 p.m. itself, with the average waiting time dropping to 81 minutes. The utilization of screening room and doctors cooled down to around 81%, and the DMG rooms and doctors hovered around 82%. Peak census came down to little below 60, which decreased the need for any further expansion of waiting areas. And the utilization of other staff slightly increased, but did not mandate any further augmentation. So what this simulation model actually helped us was to understand that how we can optimize staff utilization. Whenever you are expanding a facility, it is very much possible that you see, this is a classic example where patient load was going up from 40 to 100. But at reception, for example, you would be thinking, why, when we knew that the reception utilization was 11%, we didn't decrease the staff at reception? You see, at reception we only had 2 people, so making it 1 is very difficult, because you have billing, you have registration, you have so many things which is going on. So 2 was the minimum number we had. But we knew that even if we increase the patient load to 100 or even 150, subsequently we did more simulations also on this, that even up to 200 patients, our reception will never become a bottleneck for us, and we can continue to use the same staff, and not just saying that from 40 the patients are going to 100, we increase, but simultaneously we realized that we still needed to add additional doctors, because the patient waiting time for the patients, the time at which the doctors were targeting to get free, that is 3 p.m., was not being achieved in a scenario which was there. So this is where uh, simulation in healthcare is helping us in a big way. And I must say that we are still at a very, very nascent stage in simulation. We need to go mainstream and try to utilize simulation to the extent possible. And today, softwares are making it easy for us to, you don't need to do too much coding. It's some basic understanding of the subject, of the tools which are there that you need to do to make sure that you are able to use them in your scenario. Uh, One thing we realized that it is highly recommended that you do have master trainers or you have a centralized lab which can you can't expect doctors and others to be learning those softwares and everything. You need to have a core team. You can put them with doctors. The doctors and the staff members can give them the information. But you must have a team which develops models. You must have a team which understands the basic operations research concepts to enable simulation in healthcare scenarios. Uh, I think I will open the house for questions now.
Thank you, sir. Thanks for sharing your great project. And actually, sir, one thing which I wanted to request you, there are some participants from computer science and computer application background, along with management and industrial engineering profile. So they are very much interested to know how digitization or on data analytics or going on in healthcare. Being a practical person, you may just throw some light on these areas also for them. Just you can share what is your thought on
Sure, 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 sir. Sure, sir.
digitization.
So you see, one very important thing is that the government of India is also mainstreaming um, digital health. And how they are doing is they have this National Health Authority, which has now brought in the Ayushman Bharat Digital Health Mission. So the digital health per se, via the ABDM or the Ayushman Digital Health Mission, is giving every individual a ABHA number, Ayushman Bharat Health account. Now you have to understand that Ayushman Bharat Health account is so designed that it is something like your UPI system or your Paytm system, where each hospital will come and pair with a central registry. Your medical record, you can also keep in DigiLocker now. The government has enabled that. And if you go from one facility to another facility, all you need to do is give your consent via the OTP which they request. It can't be taken automatically, but you need to give your consent via OTP to allow your health records to be exchanged between one health facility to other. This is in an early stage today. It's picking up quite well. Even um, uh, apps like government is now moving in a very smart way. Even apps like Paytm and others are now able to create an ABHA ID. They are able to give you an option of a locker to keep your health records. So what we are seeing is that the coming 5 years are going to be very, very revolutionary for digital health, especially the way the patients will start demanding portability of their health records. Now, you go and get a blood test done. Your blood test reports can be now made available to you in your DigiLocker. So you go to your doctor, you just share your report, he will get that. You go to another hospital, you are able to share the entire record. So this is where a major shift is coming. So if participants are interested, they must look at the Ayushman Bharat Digital Health Mission, the ABHA ID, and then they have also put out MVP, the minimum MVP, we call it, minimum virtual something or something, which is the minimum requirement for a hospital, for a software to be called hospital information system, lab information system, and these sorts. I am a member of the technical committee which is certifying those solutions nowadays. Um, so I think we are seeing a lot more traction happening in the industry with a lot of people coming up, like Paytm and other apps coming up, to federate your medical record. Hospital information systems or lab information systems in another 5 years or maybe 10 years are going to become just like your Paytm and phone pay or other things. Even small doctors will subscribe to that. Doctors will have a simple login sort of thing. You will have more chat like interfaces, WhatsApp like interfaces, Gmail type interfaces coming into the hospital information systems. And patients will automatically be on apps which will have teleconsultation built in, keep their health records on that. So we are at a very, very good cusp of digital health today, sir. That's from my side.
Thank you so much, sir. Participants, who have any questions, please utilize the expertise of doctor, because he's a practical man, knows a lot of difficulties what they are facing day to day. You may raise questions one by one. Please feel free to interact with him.
Good evening, sir.
Good evening, madam.
Sir, can I ask you one question?
Sure, madam. Please.
Sir, actually, according to
can I know who you are and what's your background, so then I can respond you better.
Yes, sir. This is Bhakia. I'm a research scholar under computer applications in NIT Tiruchirappalli. Actually, if we see the hope of the data sets, video data sets in medical field, it is very, very less, sir. So if we get some video from YouTube, whether we need to have any, we need to get any permission, proper permission from the owner, or we can use the videos as such.
Ma'am, data set for, you mean some sort of a surgery video or something of that sort? What sort of?
Yes, sir. Yes, sir. Exactly. If we go for some heart surgery or brain surgery, in case of tumor prediction, if we wanted to make a data set from videos, we are sort of, we are very, very lacking of video data set. So in that case, if we try to download the videos will not be easily downloadable, first of all. So when we use some tools to crack the thing and we download it, whether we need to get the prior permission from the doctors,
Madam, you see, one is that if you must take patient privacy into account, and also the doctor's privacy. If you are anonymizing the patient and the doctor, I don't see there is any problem. But I would always suggest that if you take a video from any source, the best thing is to mention at the bottom that source is this, source YouTube, this. You can simply refer to the YouTube channel so that the other person doesn't feel offended that you have not given acknowledgement to what you have done.
Okay, fine, sir.
So this is what we normally do, and we would normally not take any video which has faces in it.
Yes, sir, of course. I could see only very, very less videos. Or the videos are like, they are not giving real videos, like animated videos they are posting. But we are very, very, very less videos we could see from the net.
Very correct, madam, because a lot of reasons. One of the reasons why, you see, if you ask us in our internal systems, we may have lakhs of videos, right? But the one reason why they are not left out in the public is also that people would get scared seeing the real blood and everything what would be there. So that is why we often would have animations to help us. And it's actually not that easy. We have a lot of doctors also faint in the first few times when they see blood. So you can understand the impact. And today with children also having unrestricted access to YouTube, I think videos which have little more visual
sir. Whatever
things should be avoided.
They show some information like under 18 means if you are okay with that, then you can proceed. They show some information.
Oh, everybody presses okay, madam. Don't worry.
Okay, sir. Thank you, sir. Thank you so much.
Sure. Any more questions?
Any other questions, please?
Right, sir. I think we can close then.
Yes, sir. So
thank you so much, everyone.
Yeah, I take this opportunity to thank Dr. ANGELRAJAN Singh for offering the insights on healthcare simulation. And of course, he's a very busy person and immediately accepted my request and delivered his. Maybe he may contact for any assistance. Sir, please, in case if some of the participants approach you for any suggestion or
Sure,
advice,
sir.
please
Sure,
advise.
sure. No problem, sir. Anytime. Thank you
Thank you so much, sir. I will be in
Thank you.
touch with you.
Thank you,
Thanks a
Gaurav.
lot. Thank you.
Thank you.
Thank you for your time.
Thank you, sir. Thank you.
Thank you so much. Thank you.
Okay, we'll take a 10 minutes break and we'll join for the next session on data analytics in healthcare.
Sir, அதுக்கு முன்னாடி இது accommodation பத்தி பேசலாம் சார்.
Sure. Actually, we have made some arrangements for accommodation. Already we blocked some rooms in our old book house, and where you have all the facilities. I think right now 4 or 5 people have already given your requirement to Anand. Please suggest what time you are going to come, what are the facilities you need, so that we will confirm everything. And Monday by 9:30 we have our offline session inauguration. So please join for that, and we have some training on all these data analytics and simulation. Kindly confirm your arrival and other accommodation requirements by possibly by today evening or tomorrow. Thank you. We'll join after 10 minutes.